So our next speaker is Dr. Pandey, and he is going to be talking on managing congenital fibrosis of extraocular muscles, my custom tailored approach. So,
thank you, Dr. Chitra, for this opportunity to interact with you all. Now, I'll be talking about a rare condition which is difficult to diagnose and treat, and it's a very rare condition seen in 2.3 lakh versus one case, so it's quite rare. Now, CFEOM is a misnomer. Primarily, it's a neuropathy, not a myopathy, as we all know. Neuropathy affecting all the part of the cranial nerve 3 nucleus and nerve and its innervated muscles, and or trochlear nerve and its innervated muscles, that is superior oblique. Now, fibrosis is variable and a secondary event to primary degeneration. Now, prevalence, as I've said, is very rare, so you may see 1 or 2 patients in your lifetime. Now, these are basically CCDDs, as we know, this aberrant signaling of the extraocular muscles by the neurons in the CNS. So its problem is with the CNS and the nerves and not at the level of muscles. There are 2 mechanisms. One is that there has to be correct axonal targeting of the extraocular muscles by these axons, which is regulated by the KIF21A, which is a kinesin. It sort of transports the material proteins to the nerves. And other thing is motor neuron development. Now, these PHOX2A, TUB3 and TUB2B are responsible for this motor neuron development. So if there's a problem with these, you can again have these CFEOMs. Now, tubulins are important for neurogenesis. Neurogenesis is neural migration and neural differentiation are very essential for CNS development. Microtubules are essential for such processes, and microtubules are composed of tubulin proteins. It's like a skeleton, and TUB3 and TUB2B fall under these tubulin categories. So if you have problem with tubulins, you can have CFEOM, and you can also have a lot of other conditions in the CNS, and a lot of other things can happen in the CNS in these cases. With TUB3 and TUB2, like malformations of the cortical development, degenesis of the corpus callosum, hypoplasia of the oculomotor nerves, absence of the cerebral peduncles, microcephaly, vocal cord paralysis, and a lot of other things can happen. So one has to look at these aspects also when you're dealing with such a patient. There can be a lot of systemic associations in these cases, like facial paralysis, cognitive behavioral impairment, Kalman syndrome, sensory motor axonal polyneuropathy, bilateral inguinal hernias, and a lot of cryptorchidism, even plasia, hypoplasia can be there. So we also need to look at them systemically. There could be ocular associations like high refractive errors, astigmatism, amblyopia, optic nerve hypoplasia, typical coloboma, sensory divergence, convergence, and Marcus-Kern phenomena, and even 6th nerve could be hypoplastic. Now, there are at least 8 types of, genetically there are 8 have been defined, like with KIF21A, you have CFEOM1A, CFEOM3B, with PHOX2A is CFEOM2, TUB3 is CFEOM1B and CFEOM3A, TUB2B is CFEOM3A and CFEOM3 with polymicrogyria. Tuchel syndrome, the gene has not been identified as yet. It has been described in Turkish family. Now, this CFEOM2 and Tuchel syndrome are recessive. Rest are all autosomal dominant with good penetrance. Now, phenotypes show a lot of variability. There's restriction of upgaze, that is sine qua non. In almost all the cases, we'll have restriction of the upgaze. And there's chin up and ptosis because of restriction, and ptosis of almost never be there with these cases. There is usually an exotropia, but these eyes could also be isotropic, and there could be variable limitation of horizontal gaze. There's poor Bell's and exposure keratitis, and poor and absent binocularity in these cases. Most of these cases have very poor binocularity. This is showing a family. You can see 3 generations, autosomal dominant CFEOM1, the grandfather, the mother, and 2 daughters, and all having a very typical mirror image presentation. Now, this is showing the younger girl. You can see there is a pattern. As eyes go up, there is some convergence, and eyes just don't go beyond primary position. They don't even reach the primary position. And the left, this is like a gaze palsy. The left side eyes are not moving as compared to the right side. So horizontal alignment can be very variable in these cases, and she has astigmatism, about 4.5 cylinder with a plus sphere. This is showing fundus is showing extortion in this case, and other eye seems to be left eye is extorted, right eye seems to be normal. And this is the other girl. She has far more astigmatism about -7, and she has also typical presentation like the other girl. Only thing is that the horizontal movements are different in both the children, and both have exotropia. Now this one is showing intorsion as compared to the previous one, the other sister. Now we don't know why some go into extortion and why some go into extortion. Maybe if the IR is tight, that should cause extortion, but here we also have intorsion in this child. This is the mother, which had also exotropia with gross limitation. This is another sporadic child, boy who had cataract in the left eye, and he has ESO as compared to that family which had an exodeviation. Now the CFEOM2, you can see eyes are almost fixed to the lateral canthi because the third and fourth, both nerves are affected in CFEOM2. This is autosomal recessive and described mostly in Saudi Arabia. And this is CFEOM3, which can be very variable. It can be unilateral, like in this one, you have left CFEOM, there's high myopia and there's typical coloboma. Right eye is showing a congenital anophthalmos with cystic eyeball, and there's also cryptorchidism and renal agenesis in this patient. So it was a very interesting, complex patient. We could not do genetic analysis, so we don't know most of it. Now, some of the NVDs with IR fibrosis could also be unilateral CFEOM because the IR is fibrosed. Now, this may be associated with MGP, facial palsy, and cortical malformations. There is hypoplastic oculomotor nerve. There could be variable fibrosis of the IR, and CFEOM3 with TUB3 has been identified in one of the reports with CFEOM3 with TUB3 variant in MED. Now, workup would include history, family history, systemic examination, motility evaluation, and AHP, force reduction test, visual acuity, amblyopia, and refractive errors. As we said, quite often they have high errors and high astigmatism. The LPS function, Bell's phenomena, and corneal exposure are important to look at because quite often they have corneal exposure. MRI, brain, and orbis needs to be done to document oculomotor force 6 nerves and abnormalities of the extraocular muscle thickness or insertions because they could also have abnormal insertions, photographic documentation, and linkage analysis. Now, differential diagnosis would include CPEO, bilateral congenital threadnopathy, which will be very rare. Bilateral Browns may be rarely, Mobius, and maybe congenital MED, as we said that this could be, if it is unilateral, it may be quite like that. Now,
1
the
minute
treatment
remaining.
could be non-surgical correction of refractive errors, as we said, with glasses or contact lenses. They have quite often very high astigmatism. Amblyopia treatment should be done, and ocular surface lubrication is important, and one has to take care of. Now, the surgical treatment is to improve AHP, to align the eyes in primary position and improve motility. Not all need surgery, so it's not that just because there's CFEOM, they have to be put to the knife. Now, the challenges are in this case, surgery is difficult due to extreme fibrosis of the extraocular muscles. Abnormal insertions could be there. Recessions need to be very large as far as you can than conventional recessions. There could be often orbital bands and safety. The poor Bell's ptosis surgery need to be undercorrected and may lead to exposure keratitis. Results are modest. Multiple surgical procedures may be required in these cases. Now, to conclude, it's rare, 1 in 2.3 lakh population, prone for misdiagnosis, congenital restrictive ophthalmoplegia of vertical gaze, it could be unilateral, bilateral, with or without ptosis, and the surgical outcomes are modest. Thank you.
Thank you very much, Dr. Pandey, for a very extensive talk and a lot of clarity given on this entity. I have a question for the expert panel on this. What is the take on anterior segment ischemia following strabismus surgery in this condition? Dr. Rohit?
In this condition, I mean, to the best of our knowledge, there is no change in the vascularity per se. Although the myofibrils are not developed and there is fibrotic tissue resulting in the large angle strabismus, but that does not alter the vascular supply. So more often than frequently we operate the 2 vertical recti often in the first go or as a subsequent surgery, and no change is observed. Occasionally we've gone on to do a third muscle to correct for a residual horizontal angle, but again in a young patient, have not observed any significant vascular problems in such cases.
No, actually, IR is always affected in these cases, and IRs are quite, they're quite important for anti-segment circulation. So that's one point.
No,
and most of these would need
but the
IR
vascular supply remains fairly
That's
okay.
not an issue. That's not
vascular supply is not an issue.
Yeah.
Very difficult to operate, especially as I was talking about the IR, because it's not uncommon that we've had, the tendon actually just splitting, the pulled into two syndrome for, when you're trying to release or assess the inferior rectus, because it's so tight, the process of hooking or attempting to pass sutures itself, sometimes, once or twice we've had it broken. But that's like...
There's no deficient ciliary circulation in these, I think, no.
Not reported as such. Not reported as a deficient anterior circulatory system there. Otherwise you would have seen a plethora of anterior segment issues also, which would, stem cell deficiency, limbal stem cell deficiency, anterior segment related issues, which are not, often they are just an isolated anomaly, at least in the anterior segment. You would have a lot of other features you may have, but at least you don't see significant anterior segment related issues.
Dr. Chitra,
have you tried expanders in these cases?
No, I haven't tried expanders. Like I said, sometimes it's very, very difficult to just be able to, pass sutures and disinsert the muscle. So more often than not, you use a non-absorbable, and you may have to kind of leave it on a large hangback so that you can do large recessions if you're able to manage. You, as Sir pointed out, you need to do large recessions in these conditions to release the FDT.
Actually, these are very tight muscles. Unfortunately, I could not show a video. This surgery was done some time back. They're very difficult and very tight muscles, and even if they are pulled into two, it doesn't probably, maybe the results will be almost the same. So they're very difficult situations that way, and results are very modest. So one has to explain to them that it's not going to be a very perfect situation for them. So,
Dr. Chitra, I just want to add one thing. Unhealthy nerves lead to unhealthy muscles, and unhealthy muscles will not have very good supply, vascular supply. And therefore, the contribution to the anterior segment wouldn't be so much. And therefore, the result of its stenotomy is also unlikely to be very, impressive or hurting. And because of the rarity of the condition, barring perhaps people in RP center, individual cases, people studying like us wouldn't have too much experience to really, talk very authentically on that.
Yeah, you see once in 10 years, I think, maybe RP center, they might be seeing more, but so very rare. So
I just had a case I've done large recessions only. You see one which was not easy to get, and still I've not got a very effective correction.
Yeah.
Because
no matter how much you recess, they always remain undercorrected.
Yes.
That's the message. So you can do as much recession you want, even free tenotomy. That may also be fine in these cases.